Thank you all for joining us. We will start at the top of the hour. All right, welcome everyone. Thank you for taking time and joining us today for our webinar, Beyond the Test, Building Trust and Enhancing Cervical Cancer Screening Outcomes in Native Communities. Please let us know in the chat where you're joining from, your organization, and one thing you're looking forward to from this important conversation. Bonjour, my name is Lindsay Petrus. I am the Cancer Programs Director, and I live in northern Wisconsin, and I live on the Bad River Band of Lake Superior Chippewa land. I have been with the American Indian Cancer Foundation going on 6 years. I'm immensely grateful to be having this conversation today as I believe in the importance of collaboration and shared opportunities for provider education to improve overall access and screening experiences for Native people, which aligns with our mission at the American Indian Cancer Foundation, also known as ACAF, which aims to eliminate cancer burdens in Native communities. I'd like to pass this over to my colleague to introduce herself and share a little bit about ACAF.
Thank you, Lindsay, and thank you all for joining us today. My name is Emily Babiak, and I've been with ACAF for over 2 years now as the epidemiologist for our cancer programs team. I'm excited to have the opportunity to help facilitate this Turquoise Thursday webinar and to provide a little background on the American Indian Cancer Foundation. ACAF is a national nonprofit organization established to address the tremendous cancer inequities faced by Native communities. Our mission is to eliminate the cancer burdens of Indigenous people through improved access to prevention, early detection, treatment, and survivor support. During the month of January, which is Cervical Cancer Awareness Month, ACAF raises awareness about cervical cancer prevention in Native communities through conversations and resources related to screening and HPV vaccination. Native women are over 1.5 times as likely to develop cervical cancer compared to white women, further highlighting the importance of today's discussion. Through this webinar, our overall goal is that you will learn more about building trust through culturally grounded approaches while also implementing evidence-based cervical cancer screening and follow-up care.
After attending this 1-hour webinar, you will be able to identify key elements of trust within Native communities and explore strategies to build and sustain that trust through meaningful patient-provider conversations. Review current cervical cancer screening guidelines and discuss approaches to integrating these recommendations into clinical practice. Interpret and respond appropriately to abnormal cervical cancer screening results, ensuring timely and culturally responsive patient care. Navigate the full cervical cancer screening continuum by effectively supporting patients from initial screening through follow-up and next care and steps. A brief survey will be shared at the conclusion of the webinar to help inform future webinar offerings. Participants who complete the survey will be entered into a drawing to win a FIGS Scrub gift card. A follow-up email with the survey link will also be sent, and the survey will remain open for 1 week. Throughout this session today, we invite you to challenge your awareness of the issues regarding cervical cancer in Native communities and how we all can play a role in closing the gap on cervical cancer. Consider what role you play in cervical cancer screening care. How can you close the gap and help eliminate cancer burdens in your community?
We want this session to be conversational and ask that you please use the Q&A feature to address any questions you may have for our providers. We will be monitoring the chat and try to get to as many as we can. And now I'll turn it over to our 2 amazing speakers joining us today to introduce themselves and begin the presentation.
Good morning or good afternoon. My name is DiSilvestro. I am a GYN oncologist at Tufts Medical Center, originally from County Nation of Oklahoma. I'm currently, however, living in the Boston region. I have the opportunity and privilege of working with Dr. Bruegl for many, many years. And I'll let her introduce herself as I get our slides loaded.
Jesse, do you want to wait for the video?
Yes, I do.
Okay. Good morning, everyone. It is morning here on the West Coast. I'm in Portland, Oregon. Good afternoon to those of you more easterly than me. My name's Amanda Bruegl. I'm a citizen of Oneida Nation and descendant of Stockbridge Munsee. I also am a GYN oncologist and had the privilege to help mentor Jessie. We met when she was a pre-med and I was a medical student many, many, many moons ago. And we're really excited to help share our knowledge and tips and tricks that we've learned over the years to help eliminate cervical cancer in Indian country. All right, let's see whose tech skills are the best here. Let's see if we can get this little conversation starter video going.
Yes. Okay, sharing now.
Do you want to share a little bit, like we've known each other for years now. Do you want to share a little bit about the pathway from your first symptom until you got to my office?
I can do that. This is what I was thinking the other day about being scared to do things that I thought, you know what, if you've experienced one of the most scariest things in your life, you shouldn't be scared of anything. So my first symptoms, my husband actually noticed, which was after sex especially, I would bleed. And it was a concern for him, and he tried to get me to do something about it for years, and I didn't until it came to the point where I was just like literally gushing. So I figured made an appointment with my primary physician, and he personally, right then and there, he did a pap smear, and I could tell by the look on his face, something wasn't right. For Twitter, kind of explained it. I just put it off, and I blame myself. I know I should have went.
Do you remember, like, when your last, screening was? Pap smear or pelvic exam?
Years. That had been years. When I did see, I was really scared to death. I had no clue. I hadn't really experienced anybody having cancer, or even anything to really know what my situation was. And I remember when we were to have our appointment, and I remember that day. It was June 12th, as a matter of fact. And that's when you told me I had cancer.
You started having symptoms, but it took Mike really pushing you to actually go get checked out. Tell me, unpackage that a little bit. Like, your body's giving you a sign, and what was happening?
I was scared. I think I knew. I think I knew something was wrong. And I was already dealing with other injuries. So I knew, I could feel it, something different inside of my body. And I'd felt it for a while, but I couldn't explain it. I just thought it was due from the injuries I had occurred. And I think a lot of us just put things in the back of our head and just kind of move on with life. And sometimes you can't, because you're moving on with life is shortening your life.
Do you think there's any, you said one of the barriers to you being seen was you were scared, and is there anything you think healthcare providers or any message for healthcare teams that they need to hear to help mitigate that fear,
The person who had told me that, they were not a very personable type. It was more of just you in, do your thing, and bye. Show some compassion. I guess that's the word I'm looking for. It's they just don't have that. You look me in the eyes, okay? So when you don't have someone look you in the eyes and tell you things or ask you questions and try to find out who you are more as a person, as to how they will deal with you. Your name. When they know your name and they say your name, that's very important.
So you had your big surgery, your radical hysterectomy, and it took 6 hours. You were asleep, but I remember coming out to Mike and we're prepping him saying this is a long surgery, so don't panic, long time to meet that thing. But how did you kind of feel after that before the path result came back, but between I just had my big surgery and the path report came back. Like how were you feeling then at that point?
I felt, like I said, when I woke up, I felt different. I can't explain what that feeling is, but it wasn't there. So I knew. I was like, wait a minute. Like instantly, it was the first thing I realized when I came to. And I did. I laid there for a minute, and I thought, are you crazy? Are you really feeling? And it's like it's not there. Like you can't bring it to be there. It wasn't there. So I was ecstatic.
Thanks so much. It seems like broadband made it just a little choppy. We're happy to provide the link to anyone who wants to see it. But I think I made a series of videos with some of my patient advocates and survivors to really highlight stuff that's so important about cervical cancer screening. And I'd be interested to see, what things sort of like emerge for people who are listening. But the things I hear with Shauna's story is sort of ignoring symptoms and shame. Like, oh my gosh, I let this go too long. This is my fault. I did this. There's something wrong with me. And then that shame becoming another barrier to participating in screening and treatment. And so I just really want to bring a face and a voice to the talk that we're going to do here today. So Dr. DiSilvestro, I will let you now bring up your slides and get us started with the conversation.
Wonderful. Thank you. What an amazing video. And I'm so thankful for her to share that story. Dr. Bruegl and I have worked together over the past couple of years, talking to many people and hearing their thoughts and barriers and fears about going into cervical cancer screening. And so hopefully we'll be able to talk about some of that today and how we as providers have addressed some of this. But before we jump into that, we would like to go over just a little bit of background. What is cervical cancer? How does it develop? And how can we screen for it, prevent it, diagnose it? So here's a few slides that we will share at the end of the presentation. So no need to take notes. Feel free to write any questions into the chat. We can try and address them afterwards. Okay, so we know that the vast majority, almost 100% of cervical cancer is due to the virus HPV, human papillomavirus. And that time frame from HPV infection to cervical cancer diagnosis usually is on the order of about 10 years. So we have time to diagnose it and intervene to hopefully prevent cervical cancer. There's many different time points, however, to prevent altogether with HPV vaccination, primary prevention. We recommend vaccination at young ages, but all the way up until age of 45 to prevent the HPV vaccine. Today will be mostly talking about cervical cancer screening and what are the current recommendations. So we'll dive into that. This is an older study looking at older data, but they do nicely present the disparities that we see within cervical cancer within our communities. And they depict here that we know that the rates of incidence of cervical cancer, so newly diagnosed cervical cancer, is higher in our Native women population. And this is true across all ages, compared in this study to non-Hispanic white women. In addition to higher rates of cervical cancer, we also have higher mortality rates. So Native women are dying from cervical cancer at higher rates compared to other subpopulations. And this is likely multifactorial, but data has shown that we have diagnosis of cervical cancer at more advanced stages. Native women travel farther to receive care and are less likely to receive guideline adherent cancer treatment once cervical cancer is diagnosed. Dr. Bruegl did amazing work and presented specifically incidence and mortality rates among Native women in the Pacific Northwest region. And she looked at all different GYN malignancies and overall didn't find too many difference between the uterine and ovarian cancer, but notable difference within the cervical cancer diagnoses. So she found that, and feel free to jump in here too, presenting your data. But
no pressure, no pressure.
I know. But did find notable differences in both incidence and mortality rates. So Native women had over 1.5 greater rates of new diagnosis of cervical cancer, and unfortunately, almost 2 times higher rates of dying from cervical cancer, which increases all the way up to 3 times higher in the age range of 50 to 64 years. So we know Native women have higher rates of cervical cancer and are more likely to die from cervical cancer. So there's a significant opportunity for us to help reduce these rates, reduce the disparities that we see amongst our people. And why is this? One thought is that there are many risk factors for cervical cancer, and that we are now seeing them in higher rates among our Native populations. So some risk factors that we know lead to cervical cancer include HPV infections. Other risk factors are low socioeconomic status, tobacco use, history of sexually transmitted infections, overall number of sexual partners, earlier age at sexual debut, and history of sexual trauma. And looking specifically at each one of these risk factors, we see higher rates of these risk factors amongst our Native communities when compared to the general population. So specifically looking at HPV prevalence, our Native communities have rates of HPV infection ranging from 20 to 30%, which is much higher than the estimated 20% of the general population. So what can we do? And as I mentioned, secondary prevention options include screening. And we have great screening techniques available to us. So what is screening? Cervical cancer screening is a broad term that encompasses a couple items. Firstly is the Pap smear test, which is what we oftentimes refer to as cervical cancer screening, but this one is one component of cervical cancer screening. And the Pap test specifically is looking at the cells of the cervix. It is looking at the cytology. And that's different than testing for the HPV virus, testing for the presence of the virus within the cervix or the vagina. Doing both together is called co-testing. And so what should we be doing? And we look at the guidelines that are currently out there, and there are a few different guidelines out there, but really, I think this was a table that really summarized it well. And this is also a changing target. And I included a slide later on that will help review some of the recent press related to cervical cancer screening. But in summary, we really should start screening around the ages of 21 or 25. And between the ages of 21 to 29, we should really only be doing cytology. So looking at the cells of the cervix, i.e. the Pap test. And that should be done about every 3 years. Then once a person turns to the age of 30, we transition really into HPV primary testing, which is done every 5 years. Then at the age of 65, if they have completed all of their cervical cancer screening and meet criteria for exit screening, then they can graduate out of cervical cancer screening. And so this really summarizes what exit screening is. Before I jump on, Dr. Bruegl, do you have any other thoughts or additions for this table?
No, I think this is great. I think maybe one thing just to emphasize is that the American Cancer Society has different screening guidelines than the other organizations. It may have implications for insurance reimbursement, and also the messaging that our patients hear. And I have a handout that I can share toward the end that kind of shows the two different models of screening.
And that hopefully with this new, I'm just going to jump slides a little bit, with the new HRSA updates that came out this month, that may be changing too. This is, again, all of a moving target. But with these HRSA updates, in 2027, everyone should be able to be covered for HPV-based testing. So I anticipate in the coming years, guidelines should be hopefully unified. Jumping to the exit screening criteria. This is really important since we are seeing an increase in cervical cancer, or we know a substantial portion of cervical cancer are diagnosed in women above the age of 65. And this technically isn't an age that people need to be screened by. So it's super important for us to make sure that patients are meeting the criteria to graduate out of cervical cancer screening. So if we're seeing a patient who's 68 and you think, oh, she's outside of that guideline range, it still will be important to make sure that she graduated cervical cancer screening. She may have not had a cervical cancer screening test in the past 20 years, and therefore you should still do a test at that time at that visit. And so for those individuals who are average risk, don't have risk factors like high grade lesions, DES exposure in utero, or compromised immune system, they at this time should be having HPV-based tests at both 60 years and 65 years. And that year timeframe may narrow depending on the type of test that's being done. So if it's a self swab, which I'll talk a little bit about in the next slide, but about 5 years HPV testing should be done within the 60 to 65 year range. And that last test should not be performed any younger than 65 years. So that's where seeing those patients who are above the 65 age range, making sure they got one within that last year will be important. So what are the tests? So we talked about the HPV-based test. This can be done either in the clinician's office or now newly FDA approved self-collection. And that can be done in the office or at home. And so these are the two FDA approved assays listed there. And then the teal wand is a specific brand that has been approved at home. But this really is an exciting time where we can now offer patient options in the clinic. Do you want the provider to do the or the HPV test? Or can the patient do the self-collection test by themselves, say in the bathroom in the office? So it really allows patients the opportunity to choose which testing they want done. And it's interesting, there's been studies looking at what do patients really want, and about 3/4 of patients are open to doing self-collection. About a quarter are not interested in it. So I think this is an important time to discuss this option with patients. And this new update allows and supports the option of self-collection, making sure that it will be covered by insurers in the future years. So are we using cervical cancer screening tests appropriately? What is our community, how is our community doing in terms of cervical cancer screening? So again, this is Dr. Bruegl's amazing work looking at rates of up-to-date cervical cancer screening amongst the Pacific Northwest Indigenous populations, and found that overall, our Indigenous communities up there are lower than national average of cervical cancer screening and much lower than our healthy people goal. And so we have some room for improvement. Specifically looking at the age ranges amongst patients who are up to date with cervical cancer screening, there was really a drop off in up to date cervical cancer screening amongst the 50 to 64 age range, which unfortunately was found to have significantly higher rates of mortality. So more likely to die from cervical cancer once diagnosed, and are underutilizing cervical cancer screening. So again, another area of opportunity. Sorry. And so what should we do after we do the after we get an abnormal HPV test, abnormal pap smear test? This is a resource that I use regularly. The app is on the front page of my home screen on my phone, and refer to it regularly for figuring out what are next steps. So I recommend downloading this application and utilizing it. It's been a great resource. And they also have wonderful resources on their website too for situations that don't necessarily fit into the application. Vaginal HPV test, there's a whole algorithm for that. And other informational resources there too. Okay. I'll hand it off to Dr. Bruegl to talk about what are next steps after an abnormal test.
Thank you. Thank you for presenting all my work. No pressure, right? Like you have the senior author and you have to present it in front of them. Like I can't imagine wanting to crawl
You
into
give me lots of feedback.
A deeper hole than that. So there was a great question in the chat that came up that I'm just going to pause. And so one question asked, does the self-collection, is that considered a co-testing method? It is not. So that is part of the algorithm for primary HPV-based screening. And so there'll be some handouts, and I'll share it at the end of our talk here to just give you a preview that'll be available for you all after the talk that you can print off and have in your offices. But essentially, you do a primary HPV testing, and that's either in your office or if you have the home-based accessibility. If the result is negative, no high-risk HPV, depending on what you look at, it's either 3 or 5 years follow-up. Okay, this is another challenge in US data where there's different recommendations by different organizations and kind of determine where the patient's at in their life and what their risk profile might be. If it's positive, there's another decision tree. Are you able to do HPV genotyping? If it's 16 and 18, then you go to colposcopy. If there is no genotyping, or if it's one of the other high-risk types, then reflexive pap smear. So somebody does come in and then you do a swab. And then sometimes colposcopy. And so the screening algorithm has become a little bit more nuanced. So let's say somebody does risk into colposcopy. This is pretty terrifying for patients. And one of the things that I do in my practice is while the patient is dressed, I go through the result and the why. And I actually pull out the app with me and I say, this is your PAP from this time. This is your history. This app helps me determine your risk of having moderate to severe precancer or worse. And then I give an orientation to the colposcope with their clothes on to help reduce some of the fear around it. And one of the first things I say to my patient is, no part of this instrument goes inside your body. They're huge, right? And someone's coming at you like that, it is just very unnerving. And so I just give an orientation to it. Sometimes I let them actually look through the colposcope itself at like a piece of paper or something. And I say, this is essentially binos for your cervix. It is allowing me to zoom in and have a closer look. I'm like, this starts just like a pap smear does, where I place you in this position. I use a speculum. I'll even show the speculum and say, this isn't that different in width from the average partner or a super tampon if you use them, to just help create some comfort around the equipment that is related to the exam. The other piece is acetic acid. The idea of acid being anywhere near your genitals does not sound good to the ears. And so I say this is a vinegar solution, also known as acetic acid. And what this does is help me see better with the colposcope. You're going to smell like a salad or an Easter egg, just adding a little humor and levity into a situation that can be really challenging. And then I just let them know I'm looking. And I ask people, I'm like, do you want to know what I'm seeing as I'm doing it? Or do you just need to be in a different space? I've had patients who are like, don't tell me anything. I'm just going to pull up some YouTube and I'm just going to go somewhere else. And then some people are like, yeah, tell me what you're seeing, And I'm like, all right, your cervix is like a bagel. Okay. It's a pink bagel and I'm looking for white spots. And I'm seeing some normal white changes, or I'm seeing a little area of white. If your cervix was a clock at like 2:30, I think it looks mild. We don't need to do anything. Or I then prep them for a biopsy, which feels crampy. I don't really kind of sugarcoat it and say, oh, it's just going to be a pinch. Like, this is going to feel like some pretty heavy period cramps. Or have you been through labor before? This is not going to be that bad, right? Like, trying to create a framework based on prior experiences can be really helpful. And then I do always tell them, I'm like, listen, you are in charge of your body. I am here to provide this care for you and that you understand it. And if it is just not happening for you today, you let me know and we are going to find a way to make it easier for you. So I really try to provide some patient empowerment through this whole process, and not just something that I am doing to their body. This is something we are doing together with permission and good understanding. Okay. Let's see here. It looks like some Q&A in the chat. Let me see if there's
I'm slowly answering them as we go through.
Oh, Dr. DiSilvestro, the first question, that kind of relates to the study you're going to talk about. So the one from Julia, so the question from Diane, how do you feel about screening for people over 65 if they're sexually active with a new partner? I think it's very reasonable to continue screening. So the guidelines sort of fit a majority of the population, but there's always an opportunity for justification and expert opinion. And many of us are healthcare providers, and we are experts, whether we feel like it at the time or not. So it may require a little bit of justification for insurance coverage, but I haven't had too much pushback in that arena. Okay, so Nicole from California. I'm not sure if this is just a California program, but after women turn 64, they don't qualify for Everyone Counts. Our patients will have to pay out of pocket to pay for a mammogram or PAPS. This is a huge barrier that our Native patients after they turn 65. I think sometimes with this is what we need to do is provide ample justification. This patient does not meet the national exit criteria to stop screening. Therefore, screening must continue until exit criteria is met. And so it's sort of like this extra documentation and pushback because their sort of AI logic is like, okay, over 65, we're not going to do this. And you're like, no, actually you are going to do this. And here's the national data to support that. And so these often require more work to be done. Is there a cure for HPV? There is not a cure available at this time. The most powerful thing we could do is actually getting people vaccinated. HPV vaccination, and according to the American Cancer Society, really should start at age 9. It's FDA approved for 9 to 45. It is most powerful before the onset of sexual activity. And there's a huge body of evidence showing that if you start at age 9, you get more finishers, people who complete the series. The gender and ethnicity gaps actually close when we see people starting at the age of 9. And so as people get older, you start to see these things sort of tease apart, where you do have racial and ethnic differences, you do have gender differences. But when we start early, that gap is not statistically significant. We have micro patterns in all of our communities and cultures, right? This is not a one size fits all data piece, but the best cure is prevention. And we hope that our immune systems will take care of it. And for most of us who do test positive, and most people do, or not test positive, but get exposed to HPV at some point in their life, their immune system will cover it. And so the best thing is to get our youth vaccinated. And then for the rest of us who are too old, myself, who aren't eligible for that, we just got to make sure that like our nieces, our nephews, our babies are vaccinated to protect our next generations.
I do just want to add to that it's extremely distressing for patients who have HPV and they can't clear it, and they feel like it's something they did, something they're doing, that if their body's not able to clear it. I find myself sometimes just reassuring patients that they're not alone, that there's nothing that they did to cause this, and nothing that they're doing to prevent its clearance. Really, the only thing that we can counsel our patients on is tobacco cessation and living a healthy lifestyle. But it is very distressing and frustrating for patients. And I wish one day we had a cure.
Yes. Just looking at a few other questions. Does self-collection meet GIPR criteria? I don't know in particular. It is being done at Indian Health Service facilities. So I serve 1 day a month doing basic GYN care at one of the tribal clinics here in Oregon. And the clinic is doing this, and we are offering it. And so I think because it is FDA approved and part of national guidelines, my sense is yes, but I do not have the definitive answer to that. Jesse, I don't know if you...
I agree with that. From other institutions that have implemented it, they've not had any issues. And I think a large part of that is that the ICD-10 and CPT code is HPV-based testing. And this new HRSA update is going to further support this. So in 2027, this should not be an issue. Just from personal experience, it has not been an issue. But that's a good question.
Um, so
Age limit for
Diane, some
vaccines.
good
Oh, no, you go
questions
ahead.
regarding ACS stuff. I'm going to pause. I'll wait on that because I think we're going to get to the discrepancies in the ACS, and I think that'll be a good time for your question. Um, let's see. The age limit for the vaccines, that's a quick and easy one. 9 to 45 is FDA approved. I find that for my patients who are older than 45 who want it for some reason or another, we really have to battle with like funding, like paying out of pocket. And some insurance companies you can tussle with, and some it doesn't work so well. So let's see. Maybe
If
I think I'll
completing
hold. Yeah.
under the quadrivalent vaccine is HPV-9 update recommended? I was told no years ago, but research changes. I haven't seen any updated research on it, and I think clinically the 4 covers the most oncogenic strains. So I don't think for patients it's worth revaccinating. There's no data for
Yeah.
that.
Yeah, there's no data for that for my patients who have extra risk factors. So I see a number of patients with persistent dysplasia and immunosuppression due to a transplant, for example. Um, I will have a discussion with them about like, hey, you protected yourself against the most common types. You are more susceptible if you're exposed to these other types. I think it's very reasonable to expand to the 9-valent vaccine. But in general, for the healthy population, it is not recommended to make the switch to the 9-valent. Okay, I don't know, Jesse, if you want to do the next slide and then some of
Oh
these
yeah,
other
sorry.
questions, which are all fantastic. Thank you so much for being awake during this virtual meeting and not doing your laundry. Oh, here's some just basic colposcopy images. So the cervix on the left is normal. And I tell my patients, I'm like, your cervix should look like a pink bagel, smooth, nothing on top of it. You can see the transition zone here between the glandular cells and the squamous cells. And this is all very normal. For people who are younger, particularly people who are younger and on contraception, sometimes that ectropion, that glandular looking part, is actually much more visible. And so you see that aceto white line being in the more outer part of the circle, so a little bit more advanced. And that's okay. That's all part of normal, healthy physiologic visions. Abnormal colposcopy can be any number of things. So you can see here that the white is like thicker and more of a plaque. You can see more vascularity, particularly in that 11 to 1 o'clock time. And then, it's kind of hard to see on this picture, but you can see little punctations. And so these are all areas of concern that you would want to biopsy. And I will often take 2 to 3 biopsies in something like this because you might not get the depth, you might not get the right area. And so I will do 2 to 3 for something that looks expansive like this. If you have a overt cancer, glandular cancers can be pretty sneaky, where it looks like a normal cervix, but not like a normal cervix. And so you'll get like a barrel shaped, where it just looks a little different, but there's not a mass or a visible lesion very well. So those are tumors that you definitely want to make sure, like if somebody has like an atypical glandular cell on their pap or something like that, an ECC as you're doing a workup, right? Making sure that glandular tissue is sampled. For more classic squamous cell carcinomas, I often think that those more advanced ones, they look like a muffin top. So something growing out of the cervix. That's a huge one. Like if you have a 3 to 7 centimeter mass, it looks like a muffin top. But if there's something that looks like a growth, coliform, or just irregular, not smooth, they tend to bleed. So when you biopsy, just be ready with Moncels and pressure, and making sure that you get sufficient tissue so that the pathologist doesn't come back with the ultra annoying, this is necrotic, need more tissue. It's one of my least favorite responses from a pathologist. Okay.
Oops, sorry. Oh, sorry.
All right, Jesse, you can take it from here if you want.
Wonderful. We just wanted to review what some results may what result reports may look like when receiving them after colposcopy, and what does the language mean? And so this is actually oftentimes a diagram I use with my patients. I have it printed out so I can circle, draw on it. I think it's a great visual for patients too, to have an idea of what was done, what was biopsied, and what does the pathology look like. So we have this continuum from normal cervical tissue all the way to the right to cervical cancer. And as I mentioned before, this progression of dysplasia can take up to 10 years. So there's a long time frame that this can develop over. Over time, too, the terminology has changed a bit from CIN1 to 3 to this LSIL, HSIL, low-grade dysplasia, high-grade dysplasia. CIN1 is the low-grade dysplasia as seen here. CIN 2, 3 really lumps into the HSIL, high-grade dysplasia. And then we have a pre-invasive cancer and then cervical cancer, which is invasement through the basement membrane. So once you get these results, what do we do with them? For patients who have high-grade dysplasia, HSIL, CIN 2, 3, or AIS, sometimes also seen as CIS, these patients need to be treated. This high-grade precancer needs to be excised from the cervix and removed. And this is done through 2 different types of excisional procedures I'll talk about shortly. But then if cancer is diagnosed, this is really important that these patients get referred over to an oncologist for treatment. Oftentimes surgery is not what this patient needs, and they can be treated with chemotherapy, radiation alone without surgery. So it's important that these patients are identified and transferred for evaluation and treatment. But once high-grade precancer is identified, these patients are oftentimes treated with a LEEP, a loop electrosurgical excision procedure, or a cold knife cone. LEEPs can be performed either in the clinic or in the operating room, whereas cold knife cones are oftentimes performed in the operating room where the patient is fully sedated. And the goal of these procedures is to remove that precancerous lesion, to treat it. And then after this procedure, patients will still need to follow up closely. I always like to emphasize that to patients. Our goal is to treat to remove this area of the cervix, but it's going to be so important that we continue to monitor long-term afterwards. These patients with high-grade lesions are at risk for having another high-grade lesion that needs treatment again in the future. And so that's why they need to continue to follow up for up to 20, 25 years after these types of lesions. A question I sometimes get is, this patient had a hysterectomy. Does she still need cervical cancer screening tests? The answer is yes, if they've had a high-grade precancerous lesion diagnosed in the past. Then you should continue for 20, 25 years after that diagnosis. 25 years after that diagnosis. If a patient's had a hysterectomy and their cervix has been removed and they've never had a history of any high-grade precancer lesion, they do not need any more screening. So earlier we talked about these disparities in screening amongst our Indigenous communities. So what can we do differently? And we'll hopefully address some of this in our some other questions as well that we may get to. But I think one thing that I wanted to highlight is something that ACAP does so well, is providing infographics, providing messaging for both patients, communities, and healthcare providers about cervical cancer screening, and really tailoring it to our community, making it visually appealing, understandable to readers. These types of educational outreach interventions can be helpful to empower individuals to get screened. Additional trainings. I know ASCCP does a wonderful colposcopy training and other different types of trainings that I would recommend any provider who's interested to look at their website for. I know some communities will do different health campaigns. January is Cervical Cancer Awareness Month, and so a great time to initiate some of those health campaigns and raise awareness. One thing that Amanda and I have seen in some of our conversations with individuals, specifically between the ages of 50 and 64, we're currently interviewing Indigenous women across the US, trying to figure out, to answer that question earlier, like, why is there this drop off in screening between the ages of 50 and 64? And this, of course, is very multifaceted. But one thing we've identified that people want is a community leader, a healthcare champion to help raise awareness, to be vocal for their communities, and be that elder, that auntie that advocates and supports other community members and taking care of their health. So finding that person in your community, whether that is someone else or yourself even, to be the champion within your community to raise awareness. Okay, I'm going to pause there and see if there's any other questions. I mean, I know there's questions I've been getting. Let's go through them. Is there anything, Dr. Bruegl, that you've seen we can go through quickly?
Or let's see. There's one for older people who have not had the vaccine. Do we have to get HPV testing once a year? So the screening guidelines do not change based on whether or not you have received the vaccine. So the guidelines remain the same for everyone. I think if we could achieve widespread vaccination within the US of all genders, we might see these things change based on a vaccinated, non-vaccinated risk. But as of now, they have not changed. And so screening guidelines remain the same for everyone, regardless of vaccination status. It's also important to know that the vaccine does not provide coverage for all known high-risk types of HPV. So the most widely available vaccine right now is Gardasil 9, 9-valent. It has 2 low-risk HPV types that are associated with genital warts, and then 7 of the, 14 to 15 high-risk HPV types that are associated with cervical cancer and other HPV-related cancers. So even if you are vaccinated, you have 90% protection against cervical cancer development, and you do not have protection against other subtypes. And as people achieve more widespread vaccination in the US, we are seeing that other types are starting to sort of emerge as more common. And so that story is still being written as we try to achieve better vaccination here in the US. I think there was another vaccine-related question.
To Rolanda's question, every time I educate on cervical cancer screening guidelines, women always ask 2 questions. 1, why does PAP testing and HPV screening stop at the age of 65, but women still get cervical cancer in their 70s or 80s? It's a great question. There's been a couple articles and publications looking at the high rates of cervical cancer in this older age. I think the emphasis should be on exit screening, making sure that patients who are 60 and 65 are getting their HPV testing to make sure that they're not at risk of developing cancer in their 70s or their 80s. Not perfect, but if a patient doesn't have HPV infection within 60 to 65, then it's less likely for them to get cervical cancer in their 70s or 80s, since we know that the infection can take 10-ish years to develop. They're at lower risk for it. But back to Amanda's point earlier, this is where the art of medicine comes into play. If your patient is a high-risk candidate, I think that's shared decision-making should always be a part of our care, and making sure that we are treating each patient individually. Oh, and the second part is gone.
You had answered already. It was a hysterectomy related.
Oh, perfect. Okay, thank you.
Yeah. There was one, so patients from Rena in the regular chat, so patients can still get the HPV vaccine if they are already HPV positive, and the answer is yes. So the probability of them having been exposed to all 9 types of HPV is low. And so it's unlikely to provide maximal benefit for the subtype that they had been exposed to. It does provide coverage and protection for the other types. And so having one does not eliminate their ability to receive the vaccine. And we know it is maximally effective well before the onset of sexual activity. It's a good question. Someone had asked, is cryotherapy still a treatment? Jesse, did you I see you wincing.
I don't practice cryotherapy. The last dive I did into it was that it's not necessarily recommended in populations that have access to diagnostic and treatments such as leaps or cones. I think those are preferred since we know that we're able to excise that region. I think that it is another tool in the toolbox that if that's what you have available, but I think that first line treatment would be a leap or a cone. Yeah. Amanda, any other thoughts on that?
No, I think we're getting close to our time, which is crazy.
Yeah.
So I am going to try to go through some more of these. Let's see. So related to the American Cancer Society guidelines, so you'll be getting a fact sheet with your materials at the end, where we put together kind of American Cancer Society and other recommendations for screening. And one thing that's unique about American Cancer Society is they say HPV-based testing starting at age 25 and nothing for the younger ages, which is a big change. But they want all HPV testing to start sooner than national recommendations, and for us to not do testing. Some of the rationale behind that is that cervical cancer, invasive cervical cancer, is so very rare at the younger ages. It doesn't make public health sense to put someone through the trauma of a pelvic exam without any like maximal benefit, right? Most people, so the highest prevalence of HPV, which is the biggest driver for cervical dysplasia, happens during like the, I don't know, 15 to 30, right? Increased sexual activity, curiosity, more partners. And so we know that people will be HPV positive more likely. People in this age group are also way more likely to clear this virus. And so with that science coupled with sort of public health evaluation, it doesn't make practical sense to be putting people through that sort of testing. That's sort of like the ACS thought bubble. And the American Cancer Society in general, across all the recommendations, they tend to be the trendsetters for making change. They were the drivers of lowering the colon cancer screening to age 45. And we know in Indian country, or maybe we don't know, we actually are recommended to start undergoing colonoscopies at age 40. So ACS really pushes the envelope, and then the rest of the US will start to fall in line in the following 5 to 10 years. I think medically speaking, either approach is appropriate. You want to know your patient population. Will they follow up? Will I see them at age 25, right? Like if you happen to have someone land in your office at 22 and you see them once every 7 years, maybe doing cytology makes sense so you can at least get something documented. And so the kind of the rationale is that the ACS is ahead of everybody else most of the time.
One of the questions, would our mixed race Native women still be at higher risk? Should we be educating the younger women differently? This is a great question. I think it highlights a lot of issues with our data as a whole. Our country is largely, I would say, their mixed race encompasses a large portion of our population, and it's not well represented or delineated in a lot of our data. And so it's hard to specifically answer your question about risk for that. I think that it does highlight an important point, though, of identifying risk factors for each of our patients and educating them on this risk. And so for younger women, I don't necessarily think we need to educate them any differently. I just think that younger women as a whole, it's a great opportunity for us to introduce this. This is what we have to look forward to in our lives. These are the options out there. Now that we do have options, you can choose to do this through pelvic exam, or you can choose to do this by yourself with a swab. And so starting to have those conversations earlier on, either in your clinic or at the community level, I think is a great opportunity for us. And I think there was another question in the chat about reading material available for teenage level. I think that would be such a great opportunity if ACAF wants to get on that. Happy to help collaborate.
A few notes about self-collection for people who don't have this available in their clinic and they are thinking about implementing it. Many providers are concerned, like, well, wait, I don't want to give up the pelvic exam. Like my patient won't come in, they won't see me. And um, it's a change in paradigm. And we are empowering the patient to decide what they want for their bodies, and giving the choice to them how they want to be screened and trying to look at it through this is a powerful choice lens. I think is important. And it doesn't mean that we don't do pelvic exams anymore. There are indications. There are people who aren't eligible for self-collection. And with your handout, we do have some very common, like frequently asked questions around who's eligible, who's not, what's the timing around menses, things like that. So that'll be available to you. In practice, I found that patients are really, really great. I'll say, hey, this is available. How would you like screening done? And, some of my patients are like, actually, there's a bump I want you to take a look at. There's something going on. There's discharge, so there are natural reasons why it becomes clinically pertinent to do that exam. And so we don't want to disempower us as providers to make a recommendation for a pelvic exam if it's clinically indicated. So don't feel like you can't. Sometimes it's really nice to have the self-collection because you can do an opportunistic, like somebody comes in for a throat swab, a COVID test, or whatnot, be like, oh, hey, you're due. Do you want to just do this extra swab? Patients are like, okay, yeah, I'll do that. You can just step out and I'll do the swab and then we'll be done. And I found that that's a nice way to kind of engage the patient population because a lot of times people are like, oh, I'm due. I didn't shave. I didn't do my nails. I don't feel clean down there, and so it's like, you know what, we don't even have to worry about that barrier because it's just you and yourself down there. And then, providing whatever follow-up is needed. And so opportunistic screening, standing orders with our nursing team so that it doesn't need a provider to sign off or give permission can be very, very helpful. And then many people say, okay, this is great for the young kids, but what about my elders? What about people with hip mobility issues? The picture that Dr. DiSilvestro showed you is kind of like, the classic tampon picture where somebody's like standing up and balancing in the yoga tree pose. And I don't know how many of us as we age are able to do that. But I coach my older patients that if there's, or even people with, mobility issues or challenges with balance, you can just lay down on the exam bed, frog leg, and then do the self-collection that way. No balance needed. And so I've had good success with my patients with mobility concerns that way. And so I find that patients are just choosing what they want and what makes sense. And sometimes as providers, we make a real big thing of it, and it's like not a big deal. Let's see. Just looking. Did we
I'm
answer
responding to
all
a
the
few in the
questions?
chat.
Okay, I'm like, I've lost.
I think you guys, I think you got almost all of the questions, actually.
Okay.
I think we're in good shape here. I think we can close out here. I just want to first say a heartfelt thank you to Dr. DiSilvestro and Dr. Bruegl. You guys are amazing. We really appreciate your knowledge and time, and really a deep gratitude for everyone attending today and took time to engage in this important conversation. As we close, we invite you to reflect on your role in closing the cervical cancer gap in Native communities and how today's insights can shape your daily practice through trust, intentional communication, timely and responsive care. At ACAF, we offer several opportunities to stay connected and engaged with our work. We have our Screener Circle program that supports uninsured women with breast and cervical cancer screening, our Indigenous Cancer Solutions Texas Coalition that focuses on survivorship, lung and colorectal cancer, and we have a free survivorship and caregiver platform we'd love to share with you if you're interested. And then additionally, we have Indigenous Cancer Solutions Oklahoma Coalition that's centered on Indigenous food as medicine and physical activity. If you want any information on any of these opportunities, we can share our email in the chat. And we encourage you to reach out. We're always looking for individuals and organizations to partner with us in this work. We can't do it alone. We're into this together. So I just wanted to say thank you there, and I'll pass it over to my colleague.
Yes, and we will send out these ACAF resources and the additional cervical cancer resources referenced by our speakers today in a follow-up email. So look out also for the email with the evaluation survey that Lindsay mentioned earlier. And really just this work doesn't stop here. It continues through each clinic visit and every conversation in our effort to walk alongside our communities in health and healing. So we deeply appreciate your time and commitment to improving cervical cancer screening outcomes, and thank you all for joining us today.
Thank you. Bye-bye.